Count. We are starting in 3, 2, 1. Please start, sir. We are live.
Okay, thank you. Welcome to the yet another episode of the Gujarat Pediatricians WhatsApp group. And this is the part two of adolescence where we had left last time. Because as you know, there were adolescence is a big topic, and there are several issues which are very important. And as we have all discussed last time, the problems in adolescence, especially mental health issues, issues related with sexual activity, drug abuse, screen time, unsafe practices, etc., delinquency, etc., are increasing. So that's why we said instead of going in a hurry last time, we stopped at half and we are continuing with the second half this time. So I will now request Dr. Ramesh Bajania to introduce our moderator and the panelists, and then Dr. M.K. Nair can take over. Dr. Ramesh Bajania.
Yeah. Good evening, all respected seniors and dear friends. So, as Nitin Bhai said, this is part two of our adolescent webinar, and we'll be concentrating on sexual and reproductive health, chronic condition and transition to adult care, and future of adolescent pediatrics. As recently at Ahmedabad, PedolesCon 25 was organized, and we could see that the content lasted for 3 days. So, as Nitin Bhai said, this is the part two, and if needed, we'll go for part three also, but we'll not hurry up because we have got eminent adolescent expert, none other than Dr. M.K. Nair, sir. I welcome, sir, and I thank you profusely for devoting your time and appreciation. Another two eminent faculties are Dr. Geeta Patil, she is from Bangalore, and Dr. Samir Shah, he is from Ahmedabad. The third panelist, Dr. Harish Pemde, is busy with some emergency work, so he might or he might not join. So, not taking much time between academics and you, straight away giving platform to Dr. M.K. Nair, sir. Over to M.K. Nair, sir.
So good evening, all of you. Last time, I think we had an enjoyable evening. It was a little prolonged, but I thought it was very good. So in continuation of that, let us have into a more difficult and controversial area, the sexual reproductive health. But I think we can manage it without any controversy. So what we will say is, as Harish Premde is not there, Madam, any of you want to ask this question, we can have it, take it later, not now. Let's start with how can we ensure that all adolescents, including LGBTQ youth, have access to comprehensive and affirming sexual health care? There is a very difficult question because lots of people have different ideas. We have personal choices, we have personal bias, etc. I must start by saying something. I had some problem with this group. I'm telling you frankly, I had some problem. And one of my students who has done so much across the country is a national trainer. One day I sat with him and then he convinced me, sir, you are doing so many other things. Why have negative feelings about it? And for me, he described the plight of lot of people with this group. Then suddenly I thought probably they are also just human like us. Why should we have a negative feeling at all? So I'm telling you from my own thing because many of the audience who listen to this may have problems. So let us start with that. Sir, Samir sir?
Yes, sir.
Samir sir? Yeah.
So very good evening and very welcome to the today's second episodes of this adolescent health issue. And sir started with a very difficult question to me definitely, and it is same for the many of our pediatricians also. So before we started talking about the adolescents, about the sexuality and the LGBTQ, it is the our own pediatricians. I just ask yourself that how you confidence about the taking this type of the questions in your own routine uh, practice, and also about the when we are discussing about the sexuality, what are the content that you have to take the care regarding the about readiness. So it's really a difficult task that of course, and it really requires a proper structured training for us. We have to release our stigma, what this sir has just now told that, and we have to come out from the our own thought process, and we have to think about the unbiased and things that we have to accept that these are the now really require things to teach the adolescents also about all about these things. So for that purpose, first important thing is the about the readiness of the our own pediatricians. And for that, we have to understand what is the comprehensive sexuality education. And according to UNESCO and WHO, it is not just about the interaction and about discussion about the sex and the contraception, but it's a structured, appropriate education that covers the comprehensive sexuality education, include the physical aspect like the puberty, reproduction, and contraception. Its psychological aspect like the emotion, relationship, and consent. And at the same time, we have to also include the social aspect like how respect the other partner, equality, digital safety, and protection from the abuse. And the purpose of this is very simple: to empower the adolescent with the acknowledge the value so they can make the safe, responsible, and respectful decision. Again, is this preparation of our own setup. After the understanding of the training and real requirement, we also have to understand our setup should be properly structured. Our OPD should be properly adolescent friendly, not just a simple pediatric OPD. We have to distribute few poster and pamphlet. It even the just a corner of the our sideboard, but it can be the really required for that. This will give a clue to the adolescent that this is a space where we can talk properly. Our staff should be trained and they have to non-judgmental, and they also having the good etiquette that they can maintain a dignity of the adolescent when they will enter into the our clinic. After this all these things, we have to understand that this conversation should not like a specific conversation, but it should be the considered as a routine conversation in our daily regular OPD with the adolescent with the proper framework. What we all know is the heads SSS, that is the home, education, activity, drug, sexuality, safety, and suicidal ideation. So all these things that should be covered along with the routine diet, sleep, sports, all the related problem. We have to give a open-ended normalized language questions to the adolescent that understand that, because they have to give some clue that we are also asking the question related to sexuality, because they will not going to open up directly with you. So we have to give them such clue that many people, children and the adolescent of your age group is now in relationship, and they having a many question queries related to that thing. How about you? We have to give them about the what are the different curiosity related to their age, and of course all these things that we have to clue is the age appropriate manner, and that is called the comprehensive sexuality education. And when we discuss the same thing with related to the LGBTQ, my again next question to the audience that how many of we know what is the LGBTQ and what that plus means? So we have to understand this language and all these different terminology that include the lesbian, gay, bisexual, transgender, queer or the questioning, and that plus that include the intersex, non-binary, and asexual genders. And we also have to understand a few simple terminology, that is the what is the sex, that what assigned by the birth, what is the gender identity, what is the gender expression, what is the sexual orientation. After knowing this terminology, we should having a good structured training and remove our own stigma, because they such children having that LGBTQ community already having their own stigma. They are bullying in the community. They having a family rejection and really a lack of the confidential healthcare. So we have to ready ourselves that we should know that all this structured thing can be given to them with a good non-judgmental and of course the empathetic manner that ultimately give them a good ultimate safe place where they can discuss their own issues. Our clinic preparedness also what I had just discussed, that is really give a good signals and visual signals to them. They are really in the safe and right place where they can get the proper satisfactory answer. And don't assume that heterosexuality is just related with the only the thing. They have to understand we having a bisexuality and the same gender sexuality also, and that's why we have to ask our questions and communication with them in a such a structured and non uh, 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 judgmental way that they have to give a good give ideation. So we have to give a proper form that will give the noun and pronoun what they want to ask for, and ultimately we also give the proper structured questionnaire that will be give them real non things that they have not considered as a different from the routine community. We have to give us some specific questionnaires that related when we usually ask for the some romantic relationship. Do you having a girlfriend? But now we have to think, and then we have to ask, do you having any partner? So such type of the questionnaires that will be usually giving the good community awareness is very, very important. So lastly, I just completing the my concluding the consideration that we also having being a doctor have to remain ready. We have to give an inclusive setup also, and at the same time we have to learn respective communication along with our own staff also. Ultimately, giving a proper alternative message that they should give proper things that they can want to discuss. Thank you, sir.
Thank you, Samir. I think you have given a long but very valid discussion on that. But what I would like to say is, because we need to summarize for the general pediatrician little more, what I would like to know, first thing that we have to do is we must understand what is this LGBTQ group, what are their problems, okay? What are the problems? Their problems are just like any other adolescent. But on top of it, they themselves feel that the society is discarding them, looking down on them, etc., etc. And when they come to the pediatrician, they think that you are also going to treat them like that. So the moment you treat them like a human being, not different from us, it's a very simple thing. A simple thing I'll ask you. Suppose, Samir Shah, you go around, come to the IAP conference with half the mush. What will happen to you? What will happen? The whole people will be looking at you as if there is something big problem. It's nothing, just a little bit of hair. You decided to do it like that. But because most of us don't do it, people feel funny about it. When people feel funny about it, you feel funny about it. You think that exactly this is what is happening to them. They are just normal people. The mush will grow back again another 1 month. So that's not an issue. But here it will not grow back. They are born with it. They have to be with it. So the doctor, the patient, the adolescent themselves, doctor, and the society has to understand. And one of the thing I just tell you, we have this Big Boss program, Malayalam, and there are two lesbian girls. They are couple. Actually, they went to court to get married. Right or wrong, there are a lot of criticism and all that. That I don't care about that. But what has happened is they are very sweet little girls, and they are so well behaved. So what has happened is the whole community has changed their attitude. Lots of people send messages that when they came first, I was dead against, but I think they are the best now. You understand my point? So it is also, there is a lot of problem on their part also. They also, because people are looking us differently, they also should not react to it. They should be nice, pleasing, all that. So that probably is the answer to summary of it. But we need to have lot more discussion on what are their problems and what they will do. Anybody want to contribute a little bit? Any other speaker want to contribute, madam?
I got a question next you are going to ask me. I think I will come to that when you ask me the questions.
Okay. What are the key components of successful adolescent vaccination program, particularly for HPV? That is what Dr. Geeta Patel will be answering. Are you?
Yes, sir. No, after that, I have got one more question where you ask now that is going to be answered by.
How can we empower adolescents? Okay, now whatever it is, you can answer,
We'll
madam.
first start with the HPV, sir, because HPV has become now very important public health intervention. Knowing the burden of the different type of cancers, Dr. Nitin Shah sir is there. If I am wrong, I think he can correct me, because initially it was only propagated for the cervical cancer, because always we know that 9 Indian women die every hour. And so we were talking only about the cervical cancer and HPV to be given. I'm mainly talking about HPV. I'm not talking about the Tdap and all those things, because this is the most important thing to be discussed on the adolescent health platform. So it was only being propagated for females, and life course approach to prevent the cervical cancer was giving 90% vaccination to the girls between 9 to 14 years, and then do the screening and do the by 70% screening and 90% the treatment. So but now we are aware with the studies that this is a gender neutral vaccine, and this HPV virus infects both men and women, and almost 50 to 80% will get at least one, more than 50 to 80%, one type of HPV infection throughout their life, and they do not have symptoms. Many of them clear by the age of 2 years, but all of them may not, and it does not go away just like that. And we know that it is spread skin to skin contact, not with the body fluid during the sexual contact. So single exposure may be enough, and condoms don't have got a limited protection, and it can happen even if we delay the sex until the marriage. So intercourse is not required for exposure. So whenever the parents come to us in our clinic, we know that it prevents cervical, vulval, vaginal, penile, anal, and oropharyngeal cancer. So we should propagate this vaccine as a cancer preventive vaccine rather than telling sexually transmitted infection preventing vaccine. That will have better impact, because we are the most trustworthy for them when they are coming to us regularly for the vaccine. And the HPV vaccine is very effective method of primary prevention. Previously also, when it was given for only females, the incidence of what reduced. So first and important component is we pediatrician to talk to them when they come for some other medical problem, injury or fitness certificate, and talk to them about this vaccine, both to girls as well as boys. This is the most important thing, and remove some myths that this causes autoimmune disease, neurodegeneration, syncopal attack, thromboembolic thing. It has got the same side effects as of other vaccines. So HPV vaccine is safe, has to be endorsed by us for the both genders. And then very important thing is, as the cost is involved, the government should include in the national immunization schedule. Maybe the talks are going on, but it is one dose and only for the females. So what is going to happen? That also is definitely gives a protection. And this should be integrated with adolescent health programs like RKSK. And we know how the HPV vaccine has come, and then it is available to give to both boys and girls. That should be talked to them. And obviously the school based vaccination is very important. That has got a better impact, and create the awareness and communication among the parents, teachers, adolescents, community leaders. You can use a social media, radio, or local influencers, so that trust will be built. But in between, when it was started, there was some problem happened, and again the many misconcepts started spreading. So it is our important thing is to propagate this knowledge to others. And as usual for other vaccine, when new vaccine is involved, we have to train the healthcare workers for vaccine administration, cold chain maintenance. Adequate supply should be available. And I think very IAP can collaborate with the Foxy or community medicine or some NGOs, and it can be taken forward. I heard many Rotary clubs and Lions Club, they are giving HPV vaccine. It may help there a lot for us. And we can go by the campaign approach by talking these things. Maybe we all should be aware of the adverse event following immunization. Surveillance should be done. Without that, you cannot do it. Periodic evaluation is very important. Very important is linking this HPV vaccine with the adolescent health checkup. We are giving iron folic acid. We are talking about menstrual hygiene, life skill education. Make it a part of comprehensive adolescent health package. Many of the parents will ask us, why now my daughter or son is not involved in that? We have to tell that earlier you give, the immunity development is better and the protection is better. So this thing should be emphasized to them. These are the very important components, and pediatricians on all the setup, government or corporate or private clinic, all will be responsible to propagate this to increase the HPV vaccination right now in the private setup. And our ACVIP has told to both gender neutral, but I think government tells only for the females. But that also will create a lot of impact. And these are the components we should follow. And this is the one which I want to convey. Thank you, sir.
Thank you, madam. I think the most important thing to remember is that we made a mistake. We as IAP members made a mistake. Initially, we started propagating it as something related to sex. Madam has said it very clearly that it has nothing to do with actual sexual activity. Even body contact can come. You don't have to have an intercourse for this. So that's a very important. Second point she said is, just like it, although cervical cancer is the dreaded complication, the whole lot of boys also, men also can have whole lot of problems related to condyloma and whatnot. So that is something. And second thing is, if you have it in the community, only protecting the girls alone will not help. Ultimately, you have to get rid of it from the community. Now, for that, government has to. The only negative about the vaccine is the cost. So, unless the government come in a big way, we may not be able to help. That's the biggest message that madam has said. Thank you, madam.
Thank you very much.
Anybody else want to say anything?
So it's like,
You send it. You send it.
sir, just one important thing that what we have to give the message that these are the vaccine. It is really available for the adolescent and it's really
Home address.
needed.
Home address.
Yeah, that's important.
Okay.
Nitin bhai.
Sorry, one sec. Okay. Now, any other comment? Any other panelists want to give a comment?
Nitin bhai.
What is this? What's that?
Dr. Nitin Shah sir is there. I think he is the.
That's why I asked.
Today he is busy with another meeting, so he is excused.
Okay. Then leave it. Then we'll go to
Yes, sir. Yes, sir.
How can we improve the access to education about contraception for teenagers? Samir sir.
Right, sir. So it's a very important and some tricky problem, and it's a really sensitive subject, and we always try to avoid when it coming in our own context. But we have to understand that avoiding does not protect the adolescent, but giving the knowledge does. And there is a one really powerful, impactful scene in our Akshay Kumar's film when their mother is upset when she discovered the condom in her teenager daughter's bag. And father, being a father, Akshay Kumar calmly responded that, should I worry that she is thinking about the sex? Or should I relieve that she already know how to protect herself? But this single line capture will really give a dilemma of us very perfectly. Do we have to respond with the fear or we really respond to the guidance? And the reality is that today's adolescents already having the easy access to the information from the internet, social media, peers, and even local pharmacy. The real question is not whether they have to be exposed to this knowledge, but whether it will be really reliable, accurate, and safe. So to improve the access and the education, I will really give the 5 highlighted strategies that including we should having a proper adolescent friendly health services where we can provide confidential, non-judgmental counseling with a flexible timing and affordable option. And that will give the adolescent proper confidently giving up and asking the seeking care with such type of the problem and where they have to go. At the same time, we have to normalize our conversation being pediatrician and treat the contraception discussion just like what we are discussing about the vaccine and nutrition. Everywhere the adolescents visit, we have to really include the anticipatory guidance about the sexual health along with the children and their parents. So parents should also get some confidence regarding discussion when they are discussing at home. So they have to give the good confidence that they can also discuss same thing at home also. At the same time, we have to open the multi-channel education that might including the school workshop, peer educators, social media campaign, and spread the awareness. And we have to give a good myth-busting session that include the common concern like do pill cause the infertility, will that give the protection lifelong? Such type of the controversial questions that we have to tackle care during this session. We also have to consider the regarding the what are the core safety measures that they have to follow, and that include indicate the simple dual protection, including the condom and the all other aspect of the contraceptive. At the end, let me end that one humor that what we usually carried out regularly when doing this session, that the when the father tell the son that the son, I just want to talk about the sex, and son replied that sure papa, what do you want to know? And that really the real our adolescents are, and we have to understand that if we give a clear message to them, they will guide it properly, and if we miss that bus, they will get from the other. Thank you, sir. Sir, you have to unmute. Sure, you have to unmute.
Sir, you have excellent presentation. You have given the so-called modern view of it. But my problem is that as a pediatrician and a good speaker, you have said so many good things about all this. But in the inside the heart, as a father or as a mother, do you subscribe to all these views? That is the problem. We are talking to general pediatricians who are working not only in the city, they are also working in the villages. So there is a cultural difference happening. So everybody need not approve the premarital sex and all that. So I think that also we should need to take into consideration. I will tell you a simple example. I won't say where, a prominent NGO, they used to do a lot of program on sexuality, and I won't say the name. So every participant you say, why don't you call sir? He will tell it so nicely. Why don't you say it? But they never call me. But once they decided to call me, I went spent 3 days with them in the beach and all that. Very nice place. Okay. And at the end of the day, they were profusely thanking me for giving so much information, blah, blah. I said, okay, the thanks, let it be there. Just answer one question. How come I have become acceptable? It's a very loaded question. How come I have become suddenly acceptable to you people? So this is Bush has come to power in US. Bush has come to power in US. He won't give a single pie for abortion, single pie for homosexuality. He won't give anything. He will give only money for abstinence. You understand my point? Then we thought you are the best person to push that idea, because you understood there's a lot of politics in this, lot of economic aspect in this, and we should not tell what you call our peripheral pediatrician take a hard and fast rule. I will put it in a different way. If a child is doing it and getting into trouble, surely you have to offer the contraceptives. But we should not create an image that it is the new normal. You understand my point? That do what you want is the new normal. No, it is not. In most families, in any part of the country, that is not a new normal. That message also we need to get to the pediatrician. You need to be aware of the community sensibilities about many of this. But technical knowledge on the contraceptives, you have to share with a child who needs it. Are you clear? So that is probably what a pediatrician should be told.
So
Yeah,
one important thing when we are going for the community work, even the many school are not accepting the immediate interaction with this thing regarding the sexuality education. So that's
I know
what
that.
we have to keep such a thing that it will be the associated part of the education, not at a prominent part. What you had said and rightly said that we have to not consider this is a new normal, but if it is happened that we have to give a proper protection rather than just taking it as a casual thing, and we have to give that knowledge to the adolescent and the parents that if it will be happen, it may be hamper there many other part related regular life also. So just keep that thing in mind when you are doing this.
So I have a solution to that problem, which I have been doing for many years. I'll never go straight to the students in a school. My first workshop will be for the teachers and about their children. The moment you talk about teachers, who are also many of them very young girls or boys, and then if it is little older, they have their own children. You discuss about their problems and make them say what is the dilemma that they are facing. On one side, you have the parental issues about what is right and wrong. On the other side, you have the reality of the youngsters. They want to enjoy at any cost. You understand? Once you do that, you do not become a bad person at the school. And the most probably the principal may be having a son or girl with problem. You solve their problem. After that, they are your best friend and you can do the program in the school. Never do with your ideas in the school. That create problem because there's a lot of commercial interest before all behind many of these. So we must appreciate, we don't become a tool in the hand of a commercial lobby who want to push ideas. Our interest is that our children should be safe. And if contraceptives can make their life better, we are for it. But that we should not say that is the new normal, or we should not give the impression that that is the new normal. I hope I'm clear.
Yes, sir.
Okay? Okay.
Sir,
Yes,
shall I interrupt, sir?
Sir, now we have got Dr. Harish Pemade also. Just for
Yeah,
your
please, sir.
Sir,
Harish?
please
Good
apply.
evening, sir, and sorry for joining late.
No
It's all
problem.
right.
We'll
It's
take up
all
from the
right.
next question.
No problem. We have kept all the questions here. But only my suggestion is the answers should be brief. Otherwise, we'll have to have 3 or 4 sessions more, which is not going to happen.
Yes,
So
sir.
I think we need the answer. From now onwards, at least the answers should be brief. Harish, that
Yes,
you have
yes.
come. Let me ask you the question. What is the most effective way for healthcare providers to initiate conversation about sexual and reproductive health with adolescents? I think it's very valid now, since we are talking about contraceptives. Yes. What is your impression?
Actually, re- reproductive health questions are very sensitive one that we all understand. So talking about it to a child in clinic is also very, very sensitive. And you cannot talk until the child has faith in you that you are going to help him. One. Second thing is that you are going to keep confidentiality, right? So when we begin talking to a child and when we express that confidentiality will be kept. And sir, in my clinic, we have this written poster in the clinic. So when I say that we manage confidentiality, we have a policy on confidentiality, and I show that small kind of a write-up that see, it is written here, this is our policy to keep confidentiality. Of course, this comes with a rider that if we discover something which can harm you or you can harm others, then with your permission, we will talk to your parents. That is always there. And that is the thing children will open. This is one. And second, you definitely have to provide audio and visual privacy. So not only what you are saying, but you have to do it also. Then when you begin asking some questions which are not so sensitive and gain the confidence of the child, trust of the child that what you are talking, you are doing also, then gradually you can switch to these sensitive questions. And you have to first make the child feel that this is not something I am talking, a doctor is talking with me only. So we can say that I get many patients who have these problems. I discuss with them these issues. So we can talk about you also. This is one way. Second thing is that we can ask that indirect question like this. Are you aware that these things happen in children or in people of your age? Or do you know someone who is having such issues? So this is kind of a destigmatize the problem and removing the guilt from the child. Then they are likely to open up. But don't worry if they are not opening up in the first session. They will open up in the second session or third session. Because it is the trust and confidence of the counselor, of the doctor or the pediatrician, then only they can talk to you. Another thing which I will definitely do and ask all the adolescents that is there anyone who harasses you? Is there anyone who talks to you which you don't like? And this question is very straight, and all children they understand it very easily. And we must ask this question because this child sexual abuse is very common in our society. And this is the question we must ask all the children because other reproductive health issues belong to the child. They will ask you, but they will hesitate in asking this question, these things, because in most cases, in almost all cases, perpetrator is someone who is known to the child, known to the family. So they definitely hesitate in raising this issue. So when we raise this issue, yes, they can come out to us and maybe we may help the child, we may help the family. So this is the way I would like to raise these issues in my clinic. And I think you were trying to explain how we can raise this issue in a group and a school. That is the way we should deal with these things.
Thank you, sir. Thank you. I think it was superb. I think you will take one more question and then we go to madam. And that is about your second question for you. Harish, there's one more. Yeah. How do we address the challenge of discussing consent and healthy relationship in a clinical setting? Consent and healthy relationship in a clinical setting.
Sir, again, we need to follow the same process that make child comfortable, provide privacy, express confidentiality. And then here we need to understand some of the life skills which child is having or not having. So assertiveness and how to say no, we have to emphasize on those things. Then we have to provide information that what the consent mean. So every child understand that without their permission, nobody should touch them. Nobody, and they definitely understand by this age what is good touch and what is bad touch. Okay. So, and same thing happens when about the consent also. So they definitely understand what the consent mean and the person is harassing or person is abusing, but many a times they are not in a situation where they can assert their rights or when they can say no. So we need to educate them in saying no or raising the voice, or whenever the child feels that they are not comfortable with someone, they should talk to other person, other friend or mother or the teacher or the doctor. So these things we must instill confidence in them. So this is one way we should raise this issue, and definitely we should also provide this information that for everything the child consent is the superior, is the most priority is of the child's consent, and that you have to demonstrate also. So before examination you have to ask, before asking some uh, this sensitive question you have to ask, can I ask you this thing, can I do this thing, can I touch you, can I take your pulse? So all these things you have to demonstrate in your behavior also. So child should understand that yes, these things are important and I have control on myself, I have right on my body, I have right on my control on my behavior, and no one except my parents have anything to do with me, and no touching, no talking, no messaging, and no that's kind of the things which can happen nowadays through the mobile, through WhatsApp and through social media. So all these things we need to instill a confidence in the child that they can raise a voice. Then only we can explain the real meaning of the consent in relationships.
Excellent, Harish. I just want to point out one thing. I'm sure those of you who are doing seriously counseling would have met this. Once the child has confidence, particularly the girls, they are willing to talk anything with you.
Yes.
They'll talk. But one problem is there. If you are, that is okay in individual case. But if you are giving a group of children, coming from college or school, something, when they go back, they tend to, bad mouth you. You ask that, you ask this, you ask that. Because they, among their colleagues, they want to say that I am very clean, I am very this thing. This is actually happening. Even many of the college girls, even with multiple sexual partners who have no problem in telling you what all has happened, but later on they regret. So be aware of that. Don't think that because they gave consent, because they were very cooperative, because they came out with all the answers, that they will not feel bad. When they go back and think about it, they start feeling little guilty. And once you feel guilty, naturally you can't take the guilt on yourself. The best person is to take the guilt. The counselors need to be careful about it. Yes or no, Harish?
Nee, that is
Possible?
very right, sir. But I think unless the presenting complaints are like this, we must not be asking these things in detail. We have to ask just some screening questions. So if the child is interested in talking about it, then only we should go ahead and talk more about it. But yes, definitely we should ask some screening question and give some opportunities to the patient or child that yes, you can ask these questions, we can discuss about it. So if the child desires, then only we should go in detail.
No, there is
Otherwise,
one
one or two
aspect.
screening
Harish,
questions are enough.
there's one other problem. If a child, if you want to know whether the child is having a consensual relationship, or somebody is actually using you. I won't say blackmail, but using you. You don't have any access to the other party. So you can know about the other party only through the expression of the child. And then without getting details, you won't be able to do it. And when the moment you go into details, the risk is there. This is what I wanted. I wanted other people who are just starting counseling to know that it is not such a simple area. You yourself can get into trouble. Because
Yes,
children will
definitely.
later say, yeah.
Definitely, sir. That is what I am saying. That is what I am saying. You just ask few screening questions. If the person is interested in talking, then only go in detail. Otherwise,
Okay,
we can leave.
perfect, madam. Okay, thank you, sir.
Sir, can I
Geeta,
add, sir,
yeah.
this about this counseling when we do for this, what I personally felt there is a conflict in our mind because there is a confidentiality we say, but there is a POXO Act also is applicable.
Yeah.
So in this our Indian context,
Yeah.
we have to be extremely careful. That I feel so, sir.
What do you write in the file is very important. On one side, you have to write things in the file. On the other side, you cannot write also.
And you have to report if it is there.
Yeah, that's of course. Reporting is a
Mandatory
most
reporting.
important one. Mandatory. Okay. Okay, madam. The next question will go. That is, what is the role of a pediatrician in navigating and supporting adolescents who are questioning their gender identity?
So this is an excellent question because many of the pediatrician may not be aware also about this thing. We know that adolescence is a period when they explore their identity, including gender identity. And we know that it starts from the age of 3 years only it starts establishing, but now it comes to the picture and they come to us about that. And we know that if this gender identity is incongruent with what the sex is assigned at the time of birth, still the issue is more because there is a discrimination, they are not accepted and they are victimized, and many times there is a stigma. So this now we use a neurodiverse word. Why should not we use a gender diverse word? So that will give a more acceptance. And we don't have proper training for that. We don't have any standardized treatment protocols. Neither the research is done for these children. So this affirming care to the child adolescent who comes to us is very important. But apart from that, this we have to be very cautious that transient exploration of the gender identity is also common with the adolescent. So immediately we should not label that, and keeping in mind that there is a stigma, discrimination, non-acceptance. So it is a definitely it causes a mental distress which is known as gender dysphoria, and we should be able to pick up that because as you told that everybody has got right, and these all gender diverse also have got their rights. So we have to respect that, use the inclusive language, already it is told, and we should give a non-judgmental space, allow them to share their experiences. And there is a little again dilemma. There is a confidentiality, but we have to balance with the legal and ethical responsibility and parental involvement. So normalize their identity exploration. It is a part of healthy adolescent development. Pick up the gender dysphoria. If it is very severe, we should know about that. And this transient exploration should not be labeled, because many times they are curious, they are exploring. But if it is a persistent, definitely we should deal it without pathologizing this, because it is very important. So we should give a psychosocial support, screen their mental health problems. Main thing is family, community, society acceptance. So we should emphasize that gender diversity is not a disorder, but it is a part of human variation, and it will be accepted in a better way. Maybe media is also coming forward with many things, but it is not depicted, it is dramatized. So give a correct picture and give a proper education to the adolescent parent, and give them some resources to know about that. And maybe psychologists, psychiatrists, endocrinologists, all should be there. Never try conversion, because many times I have been sent one patient of one gynecologist grandchild to tell that she is doing, my grandchild daughter is doing, please try to counsel. Then we told that we are not doing for conversion for these things. Gender affirming care is required, and support the self exploration of their gender expression also. And where there is a documented gender dysphoria, we need to take a help of endocrinologists properly, adhere to the international guidelines. And very important, if they are on put on something, we have to monitor their growth, bone health, psychosocial adjustment. So inclusive policies are very important. Try to promote awareness in community to reduce the stigma and discrimination. I know that it is a very challenging thing. Legal rights are there. So we pediatricians go beyond the medical care. Every adolescent we have to give holistic care. And why not gender diverse also? Sexual or different sexual orientation also. So we have to give compassionate support. We should provide the resources, guide the family, society. So gender diverse adolescents also lead a healthy life. They will be resilient, and they will have their well-being. So this is the way we should navigate, help them. This may be a very breakthrough to talk like this, but this is required to be done.
Sir,
Thank you, madam. I think this section we have taken 50 minutes.
sir, can,
Purposefully, I allowed it because, one second, because it is a most complicated area. The further questions will be easy for any pediatrician. Okay, sir.
actually, it is said that we must ask the person. In English, it is rather real easy. They say, what are your pronouns? In Hindi or other language, we can say, how should I recognize you? How should I call you? What is your preferred name? Okay. So gender identity is a choice of the person, or given by the person himself or herself or itself or themselves. Okay. So that is one thing. So what is required for us for the pediatrician? I think if one word, if I can say, it is the respect. Respect the judgment of the client. Whatever they choose, whatever they say, we have to respect. If we can gather this respect, then everything else will fall in line. So many a time this happens that we don't know about the diagnosis and management of some condition, we read about it. So if we respect our client, this client is saying, who was the male at birth, now say that I have a feeling like a female, I want to dress like a female, then the pediatrician, if they have a respect, they will explore what is to be done. So just one thing is respect and non-judgmental thing. Others thing will come through in line.
Okay, now let's go to the next category of questions. Again, starting with Harish. What are the biggest challenges in transitioning adolescents with chronic medical condition from pediatric to adolescent care? What are the problems? I think we need 1, 2, 3 answers only. Now, otherwise we will never finish, even at 12 o'clock. Let's go quickly now.
Yeah,
1, 2, 3.
Yeah. The problems are that neither the family is ready, nor the pediatrician are ready, and nor the adult physicians are ready to accept the child.
Okay.
Biggest barrier is with the family. They don't want to leave you. They want your care only. And because care by a pediatrician is very much caring, and care by an adult physician, there the patient himself has to take care of themselves and not the parents. So fundamental differences are there. And because we do not have any written policies, and this is traditions are also not there, so definitely this is very much challenging. But is one word only, sir. If we try beginning this transition from around age of 17 years, take about 1 to 2 years for the transition, have shared care by yourself and the adult physician, and then transfer this patient to adult physician. That is the way we have to do it.
What you are suggesting is we must have a license with adult physician. Many often it may not be possible with the general adult physician, but it may be possible with the specialist.
Yes.
Okay. For example, diabetic, you can involve the diabetologist. Nephrology problem, you may involve. General adult physician may not be so much interested, but neurologist, for example, a child has a neurological problem. If you discuss with adult neurologist, sir, we need your help. Naturally, even if you didn't need the help, say that, sir, I need your help for this one. So he get interested, and slowly he will say, okay, I've been coming here too often. Why don't you transfer there? Okay, the mother is happy, child is happy. This may be a simple technique you can do, but it may not be possible with a just general physician. But at least with a specialist, it will be easy. Okay. Okay.
Sir, my saying is that it is very, very difficult to find a general physician. Every general physician is an expert in something. So it is easy to find super specialist, very difficult to find a general physician only.
Okay, understood. Same thing I was saying. So, Sir Samir, sir, 3 answers only, just 3. What are the 3 things? What strategies are most effective in promoting medication adherence in teenagers with chronic illness? For example, if you take diabetes, whether they will take insulin, if you have chronic asthma, will they take it? It's like that. Chronic illness, or even much more important, the epilepsy, if you take the medication properly. Sir, your comments.
Right, sir. So, sir, there is only two things that what we have to understand. First important thing, what is the thing that preventing them to the remaining adherence to their medication?
Okay, okay,
That
very good.
what we have to understand first, and that including the whether they want to control themselves and their lives independently, whether they having a really get the some trigger factor that will really not properly supervise and that will give them something unpleasantly because of a continuous nagging by the parents, some side effect or some stigma that may lead to them to not utilize the proper medication. They feel something, they are just taking away their own independency because of the adherence, and sometimes some miscommunication that happening, and that ultimately lead to the non-adherence to the management.
Okay,
All
sir.
these things will be taken care if we take their involvement in our decision making and treatment planning. So if we give a involvement of the involved care of adolescent in decision making, at the same time making the protocol such along with the proper support of that own peers, that giving that they are not only the alone, and give a proper parental guiding to give the motivation rather than nagging them for the proper adherence is most important thing that what we can do.
If you can, I think excellent answer. If you can have a diary in which you record the time you are taking the medicine and all that. When they come next time, even if there is a little lapse, oh, congratulate, you are so good. You are taking the medicine exact timing. You are taken all the dosage. Congratulate them. Make them feel great. You are in command, not your parents. Most of them will like to be appreciated for taking such decision. That may be a good way of getting good adherence. Okay, sir. Thank you. Now, Geeta, how can we empower adolescents with conditions like diabetes or asthma to take ownership of their health management?
In a short, I think most of the things are told about the basic that
Samir has already said it. Yeah.
independent they want to be, they have got their identity and peer influence. I am going to talk about only diabetes and asthma.
Yeah.
And maybe epilepsy, but commonly we encounter what it is just as a prototype to tell that, see, there are a lot of challenges to adhering to the treatment because their lifestyle has changed, they are more outgoing, they have got a lot of stress in the life. So if you empower them, definitely the control will be better and the outcome will be better. So we should give them a age appropriate information, not to tell a diabetic child you are going to get a renal failure or eye problem. Tell them you are going to get into, if you don't take it, your blood glucose will come down or it will increase. You may miss the school, you may not be able to take part in the sports and all these things. So we explain to them the medication, what are the triggers and complications. So they are very digital native, they are very impressed if they can afford blood glucose monitoring. I have seen those patches, they are very happy. They keep a, sir has told, asthma diary, inhaler tracker, they are very happy. We can tell them how to interpret the symptoms of hypoglycemia or asthma exacerbation, and we can involve shared responsibility, how to take the insulin, what dose, what are the schedules, what diet, activity and trigger, and respect their preferences. Some of them don't like inhalers because they want to hide from their friends, they use a rotahalers. Accept it. And sir has told that encourage their goal setting and appreciate if they do it, if they regularly take the blood sugar, they do it. So very important is parent-led management should be shifted to adolescent-led management. It should be gradual but should be effective. Obviously parent safety net should be there, and encourage them to have a problem solving. Different situation you can have a role play. Here we have Dr. Raghupati in Bangalore. He tells them when you are in a sports, you are in a traveling, how you will adjust the dose. It is very effective. And praise them when they do a proper way. So there is a stigma and embarrassment. They are frustrated. Why I am like this? So you create some support group. Peers also support groups are there. Encourage them to talk about their mental health, stress, coping strategies. Tell them what they need not have to hide. And maybe certain newer things like how to use a peak flow meter, continuous glucose monitor. It is very important. Talk to the teachers or peers and family to support them. And we have to shift adolescent early from pediatric to adult health care services. Already it is mentioned. So they should learn themselves how to manage the prescription, schedule the appointment, advocate for themselves. It will reduce the chances of complications. So moving from dependence to independence is very important. Shared decision, self-efficacy building, psychosocial support, and use of technology. So they will develop the skills and confidence, they will empower themselves, and we play a major role here. Very pediatricians, families, schools, peers, all will play major role here to manage these diabetes and asthma, maybe other chronic diseases also, sir. So I just shortly told, sir. There are many
So
other.
what madam is emphasizes, even while you make them aware of the chronic complication, if you don't adhere, don't push it too much. Give them some awareness that if you don't do properly, asthma can lead to COPD. If you don't have this one, the diabetes can give you nephral problem. We just, even when you make them aware of all this, don't push it. Instead, what we should have a group, diabetic group. They must have opportunity to come together, discuss with each other, and say how I manage, how do I go to picnic, how do I do this one. Those groups are extremely useful. But for that, an individual pediatrician may not be able to create group, but as hospital-based groups can be created. I think that is the best way. You have to have a group. In fact, we are doing that in Trivandrum. We have seen diabetic thing. They come and enjoy and go, And the process of enjoyment in between, they also learn what are the things to be done properly. Thank you, madam. That is great.
Arranging camps are also very important, sir.
Camps, arranging camps. Very good, madam. Now let's go to the next category, a future of adolescent pediatric. Harish, what new technologies or innovation do you see having the biggest impact on adolescent healthcare in the next 10 years?
Sir, I will very quickly say only three things.
Yeah.
One thing is about eliciting history of social media use, technology use by our client or adolescent. We have to learn how to elicit this history and how these things are impacting our client. So how social media participation of the patient is impacting the health. This we have to learn very clearly And many of us may not know details about the social media things. We have to learn about those things, then only we can ask those history and see what impact they are having on the child's life. This is one part.
So you are saying
Related-
control on social media. You
Yeah.
have to teach them their social
No, no.
media.
Just to illustrate how much they are using and what impact social media is having on the adolescent. This is one part. Second
So
part,
the problem
using,
is, yeah, okay, go ahead, go ahead.
second part is using various kinds of technology available. Uh, I think everyone knows that psychologists are now doing counseling online. They are not meeting often, maybe once or twice only. Rest of the sessions are conducted online through the video calling. So this also we have to learn the telemedicine part of it, which is some of us are using it very nicely, but we have to use it more and more. This is very convenient to the doctor and to the patient also. And third thing is use of artificial intelligence. And sir, I think we need to learn how to use various artificial intelligence. Yesterday only we had 1.5 hour session on use of artificial intelligence, and this is very, very useful. But we have to be very, very careful also. It is like a Ferrari. If you don't know how to drive it properly, you will end up in having some accidents. So, but we need to learn various AI and need to learn which AI to use, how much to use, when to use, for our benefit and for benefits of the patients. These are the three things I would say now.
So the major point you said was how to control, your social media use. Yes or no? There's a major item.
No, sir.
For
I
yourself,
we must be
self-control.
aware of social media so that we can elicit proper history from the adolescent, that how they are using social media and how social media is impacting them.
Yeah. But the problem for the adolescent is my wife has given me this cashew nut packet, whole packet, and you would have seen me eating it left and right for so many years. I am not able to control it. How do you expect the poor child to control it?
No, sir, I'm not asking them to control. First thing is knowing how much they are using and what they are using. So eliciting that history is also very important, and we shall not be able to elicit those things unless we know about it.
Because I said that my dinner is going to be late. Because I said my dinner may be late, even 11 o'clock, she got me a lot of tea and this one. And I am sitting and eating it left and right. So that is, see, we must think like that. Even while you say that you control, even we don't have control on so many things. It may not be dangerous thing, but still the point control is a different issue. Anyway, that's a good point. Next one. Samir Shah, what strategy are most effective in promoting? Sorry, hold it. How can we address the growing health disparities that affect different adolescent population? The health disparities in different adolescent population, the rich, the poor, the downtrodden. Yeah.
Right, sir. So here we have to really require again the multi-level response and approach, because equity is not about the giving the same to the everyone, but it is about the ensuring that each and every adolescent get the real thing that what they really needed, and it will really require a proper tailored solution, and that will start from the policy making from the different aspect of the our health services that include the proper universal adolescent friendly health services can be given the proper subsidized way to the everywhere. Same time, we have to really require the proper healthcare level planning that include the training of the pediatrician in a cultural competence manner. What you have said in your first my first question, that is important in the cultural competence pediatrician. They can give a proper structured training that can be given properly in a different workshop or the whatever the way. So they will require a proper training of the healthcare. At the same time, we have to give a community outreach with a proper structured planning of the community camps. Telemedicine, what just now the sir has said, is a very important thing. We have to give it as and when we can give such type of the immunization. What madam is told that everybody get that immunization in a proper way. And at the same time, ultimately, we have to give a proper data monitoring that everything is going properly, competitive way, that what we really give, that non-gender bias, non-LGBTQ bias, non-poor and non-poor people, that getting the everything. So this is the way where we have to build the that into the policy level, our own level, and community level, sir.
So in a way, you are saying that there are three groups. Suppose we say the rich with don't know what to do with the money, the middle class somehow manage it, but you have all the facilities, but not too much. And then the poor, really poor, who actually is fighting for life. Now, all adolescents need some basic need. So that basic need has to be kept, met. So we make sure the government, we can't do it, but the government has to make sure that everybody's basic need had be. If you talk in economic terms, you call it, there is a want. There's want as well as need. All the basic needs have to be met, but not the wants. Wants are something beyond that. When you get, you want 100. When you get 100, you want 1,000. When you get 1,000, you want 10,000, like that.
No
Your
end of that.
want will go on increasing. But that is okay. But the basic needs have to be fed. And that if you don't get, we actually as a intermediary person may put them into contact with authorities who can make sure that they get the basic need. Are you with me what I'm saying? I'm
Absolutely,
particularly talking about tribal belt and all, where they don't get even the basic need. The want, forget it. Adolescents will have all sort of wants, and on one side, the rich one is going mad after the wants and getting into trouble. The poor ones are, very poor ones are really not getting even the basic need, protein deficiency, all lot of things. So I think that we need to target that way. That may be a good answer. Thank you, sir. Yeah. Anything you please say, you want to say something.
yeah, that's why now the telemedicine come in the way of big way, because such type of the tribal areas where the doctor not able to go as a specialist, they can give us some community based activity on telemedicine.
Okay, and one other thing which is out of the way, I'm saying, I feel that the biggest this thing that we have done for the people is making ultrasound not useful to the public. I think it's high time that that law is removed. What is happening more than 100 times more than the stethoscope is a ultrasound that can create
Good.
lot of help to the thing. Even the nurses can be told, if somebody is coming with acute abdomen, just have the ultrasound say. You need not be specialist, but at least you will know there is a serious problem. So that is something also we need to emphasize. The use of ultrasound. Now the legal formalities are so much that most people don't want to use it, but it should be used. I'm thinking of a day when India ultrasound will be available to by every doctor, every nurse. Okay. Now, next one is how can we better train pediatric residents and other healthcare professionals to meet the unique needs of adolescents? That means adolescent training to the pediatric resident, which I think we must do. If
Yes.
not today, 5 years down the line, we are going to have child adolescent, departments. There's already the talk going on, but
Sir,
people are scared to get into that.
sir,
How do we train?
Sir, I think this is a noble thought what Samir has and everybody feels. To achieve that, we need to train our residents as well as the pediatricians. And
Yeah.
residents, we know the adolescent is such a growing segment all over the globe. And their problems are unique. I'm not going to highlight puberty, growth spurt, mental health, reproductive health. Just now we discussed substance abuse, nutrition, chronic disease management. But in our pediatric residency program, and many healthcare training curriculum, this is not structured way it is put there. So this strengthening the training will help us to improve the care and outcome. So there should be a mandatory rotation in this residency program, but we don't have many places adolescent friendly health services. We don't have adolescent female or male wards or ICU. And the subjects what I mentioned now has to be discussed elaborately. And apart from this clinical knowledge, we should teach the communication skills. See, many of them are not using simple heads, simple screening tools to diagnose certain things. We say that early diagnosis intervention will have a better outcome. So this will be achieved by doing this. And confidentiality and consent, teaching the legal and ethical aspect is very important. Simple thing is, I have my personal thing is motivational interviewing helps them a lot, and everything should be taught in a culture sensitive way. And they should start working with the multidisciplinary team. When there is adolescent healthcare, we have to work with the psychiatrist, psychologist, and physiotherapist, and many people. So training in the team based approach is very important. And role play to practice how is the communication skills, or you should have a standardized patient encounter should be described. The case discussions on the ethical dilemmas should be discussed, and we should start a research, because many times the thesis topics are not adolescent healthcare based, so the professors can do that and train them in the advocacy skills. In the school health programs they should be involved, and residents should be taught to support these people in a chronic conditions for transitional care. And it is not that only the residents, but we have to train the faculty also to mentor these residents. And as Samir already told, CME program, workshops, online modules, and interprofessional training. See, because it is adolescent is for everyone. Now, all endocrinologists or infectious disease or critical care, everybody should know about this. So meet this unique, our target of noble target of giving a good adolescent health care. It is obviously required that pediatric resident program should move beyond our traditional only pediatric training. We have to have a appropriate communication skills, medical legal issues, psychosocial health problems, and how to do transition of care. All the things should be included, and this will help to we can build a good pediatricians who can address the challenges of the adolescent healthcare in the next century, in the coming century. So this is the way the residential program should be modified.
Sir, can I say something? MKC sir?
Yeah, please, sir. Please, sir.
There are certain things are added now, but may not be all the thing. Harish Pemde sir will be more expert in these things.
No, I'm not repeating what you said. I think the critical point is the age of adolescence, age of pediatrics. In many departments, it is still 12 years or 14 years. So in PG training, we learn by treating the patient, by talking to the patient. If we teach them everything and we expose them to adolescent up to 12 years of age only, they will not learn anything actually. So I think biggest advocacy effort is still, I am feeling it bad that even after 25 years of IAP's declaration, the child's age is up to 18 years. I think about 70-80% of the departments of pediatrics in the country are not following this age. So I think biggest advocacy required is this one, whether this is at NMC level or government level or whatever level it is. The age of pediatrics should be followed uniformly till at least 18 years of age. The day we do it, all the things will fall in line gradually. In my hospital, we are treating up to 18 years of age. So our residents are definitely exposed to the patients up till 18 years of age. Although most of them have some physical illnesses, but we do have a very active clinic. So many of them are exposed to other problems also. So this is the critical area, and which is the biggest barrier for this training. So again, IAP and AHA has to take it up, and our members who are in various teaching institutions, they have to take it up with their administration that we can increase age up to 18 years, and that will facilitate all the training of our resident and what all the topics mentioned by Dr. Geeta Patel and Samir, and we know about it. All these things will happen only when patients are coming up to 18 years of age.
I totally agree.
PMD, nothing will happen without a executive order. And the executive order can only be made in Delhi, not anywhere else. So what you need to do is the senior people in AHA need to get together in Delhi and come out with a comprehensive statement, which of course endorsed by the executive committee of AHA, and go to the government of India. It won't happen easily. I know that. It won't happen. We already have made a mistake of approaching the government and in a loose way. And what the government did, typical bureaucratic, they asked all the medicine people, do you want to give away the pediatrics? That's the wording was like that. So naturally, they will say like they are like children who have not been using the toy for last 6 months, but a new child come and pick it up. You say, oh, it's mine. I get excited. So that mistake we should not happen quietly. And the only way to do it is you will have some important person whose child has this problem, some problem or other. You help them solve the problem and then do it. I'm telling you, this is not a simple thing I'm saying. I got 18 faculty or 18 positions in CDC only because one important person, child had counseling, needed counseling. And after that, he was so happy. He said, sir, what do you want? Tell me. And he just went and did it. You get the point? Something like that. All these VIP people in Delhi who matters a lot, they will have their children, help them with their children, and strike when the iron is hot. There's no other way. Sitting in Trivandrum, I can't do anything. Sitting in Mumbai, he can't do anything because none of these people are important for government of India. And local medical superintendent and all cannot do anything because they will say, what is the rule? What is the government recommendation? Please do that. And Harish can do and take it as your life mission. Harish, take it as your life mission.
Okay, sir.
Nitin bhai,
MKC, I will just add to say that,
Yeah.
in public hospital, they may be bound by rules and bureaucracy, but in private hospital, we are all treating till 18 years. Like in Hinduja hospital, up to 18, I can admit under my care and one question. So that's number one. Number two, I think the pediatrician have to understand that good for the community and for children, that their practice is receding as far as small children are concerned because of breastfeeding, immunization, nebulization, and so many other things, preventive care. There are hardly any sickness. So even immunization is going into public health. So if they train themselves in adolescence, which is not that difficult, like say training in oncology, right?
Yeah.
And they can themselves improvise on their practice in adolescence, because today adolescence is a major issue. And if adolescence can be managed by pediatrician, the parents will have faith because they have been seeing the pediatrician right from childhood. So if the pediatrician instead of saying, no, okay, I don't deal with the adolescent, you go here, go for counseling. If he learns a little, 6 months, 1 year course, something, and become a little smarter, his practice can go up. At least in private sector, that's doable. And once 10 people do, another 20 in the area will have to do it because other they'll be left out. I mean, that's the way I see it. And I'm sure Adolescent Academy is growing leaps and bounds. This was for the simple reason that pediatricians want to now get trained into adolescents so that they can manage at least 6 out of 10, if not 10 out of 10 problems that an adolescent faces in day-to-day practice.
Then there's a third
It
angle.
is, sir.
There's a third angle.
Yes, sir, I agree.
That is,
Sentence. It is the willpower of the pediatrician or the concerned head of the department. This can matter. For Kavavati Hospital also, we did not have any executive order from the government. It is our HOD, Dr. A.K. Datta said, now we will see up to 18 years of age, and that is how it began. And we are seeing up to 18 years of age. Okay.
no.
So VK Paul, I talked.
Yeah.
Who is stopping you to see children up to 18 years of age?
No, that is not a correct answer. No, that is not a correct answer.
No,
I'm telling you, a very senior pediatrician Gochin got into trouble because he has seen a patient, above 14, and the patient had some complications. So everything was said, you are not consulted an adult physician. Don't say it like that because, see, we should not create exaggeration to the pediatrician outside. They may do in good faith, but they may get into trouble. So let's not do that.
there is one thing which is documented. Documentation is that adolescent health topics are part of pediatrics curriculum in CBME MBBS curriculum.
That's okay.
Similarly, for MD pediatrics also, adolescent health topics are there. So we can claim that pediatricians, it is the pediatrics which have the realm of adolescent health under their training. So they can see children up to 18 years of age. but we are talking of a policy so that such patients are taken care of in OPD and indoors and wards of the pediatrics. You are right. Some executive order is required from the government.
Yeah. Thank you, sir. Thank you, sir. I think we'll come to the last one, and I won't go further. And that is the Gita that we have said already. What is the single most important message you would want to send to parents of adolescents today? This actually all the panelists can, especially other guests. I can see Samir Dalwai and all that. Whoever is not in the panel also can.
Can you repeat the question? There was some connection issue.
No. What is the single most important message you would want to send to the parents of adolescents today?
Should I tell, sir?
Yeah. You start. Anybody, all the panelists
Stay
can.
connected, sir. Very short. Stay connected, listen without judgment, guide with empathy, and let your adolescent know that no matter what, they are loved and accepted. That is the message to the parents.
So don't ask the question, didn't I tell you? You didn't listen to me. Now you got into trouble. You suffer. No, don't say that. Better you didn't listen to me. It doesn't matter. We all do like that. But you are learning from the mistake now. Take that attitude. I think that is a message that Madam wanted to say. No, don't
Yes.
blame them, because I always say, let them venture out into something, make mistake, learn from the mistake when you are there alive to protect them. So that when you are not there, they will be confident to, venture into the world. That's the message that you are saying.
Yes, sir. Yes.
MKC, I would say to the parents of adolescents whom I see that, you were treated differently by your parents when you were adolescent. Don't think the same rule applies now. I'm sure you would have felt little difficult, little bad the way your parents might have treated you, not necessarily, but you should not repeat the same mistake and treat the adolescent as per what the science believes today. And based on the milieu today, we are all fixed into what we were taught as a child or we saw. Like today, if I go to a hotel, I think the idli should be available still for 5 rupees and 10 rupees. When I see it for 100 rupees, I think it's too much of charge. Whereas my child will say, Arey, it is so cheap. The is that our mindset is fixed to our childhood. So parents should not thrust upon what they learned as childhood, how an adolescent was treated, that is themselves, on their children, and try to behave in a different way. And maybe we need parents group also, which will also help them to. Today schools are very open, and schools also have a lot of teachers who are very open. They have a child counselor in many good schools, and through that, I think the adolescent parents' attitude toward adolescent is changing.
Okay, thank you, sir. That's a very good point. Okay. Anybody
Same
else?
thing.
Other panelists? Sir, please.
Same thing regarding the being a techno-savvy pediatrician. I really say to my parents that don't pull the plug. Keep the communication open, that they can say something as and when required, and they take their own help.
Yeah.
Okay. Samir Dalwai. Yes.
Namaskar and good evening, everybody. I think mother still feels that a 4-year-old goes around doing mama. Don't expect a 14-year-old to behave like a 4-year-old. Accept that to be normal. Second thing is that you need to give time and think rather than just follow advice that you get from here and there. So though we want adolescents and we want pediatricians to consult and counsel adolescents, there is also an important to have a quality training, because unfortunately people are just picking up something from social media and then advising it. So parents are also doing that. So the pediatricians and the adolescent counseling must be of a quality where there is a quality in what we tell the parents and we tell the adolescents. So parents have to keep, since you asked what the parent should know, it is not a simple give and take equation. They need to keep focusing, giving time and thinking about the adolescent before interacting with the adolescent.
Yeah, but there's also one problem, what I would like to say, there's also one problem, and that is in our childhood, even if the parents were not so good to us, some mistake happened, we accept because after all is my father, is my mother. But the present child will not accept it. Go to hell, he will say, or she will say. So that thing, I think parents need to be told. They are not willing to accept anything from anybody, even if you are a parent, teacher, professor, whatever it is. So that difference, I think parents need to realize. Okay.
Thank you, sir.
Good evening. I want to add, sir, Dr. Hima Bindu
Please.
here.
Please, sir. Please.
I'm sorry, I'm driving, so I'm not able to put my video on.
No problem. Madam, just tell your name and say.
Dr. Himabindu Singh, sir,
Oh,
chairperson.
sorry. The chief is come. I didn't know that.
No, no, sir, very
I
interesting
thought I saw
discussion.
your face for a flash. Now you have come back.
Yeah,
Yes, madam.
yeah.
Please
So,
give your
so
comments.
I was just very interesting discussion, and I was following Dr. Geeta, Dr. Both Samir's here, and of course Bajania and Dr. Nitin Shah talking about adolescents was very nice. And
He can talk on any topic.
yeah, yes, sir. So Krunal and all, Samir, even Harish Pemra, I was also really endorsing so what Dr. Harish was saying. We had in the HA tried this year, and we are going to still advocate. Advocacy will continue. I had gone to the ministry to put a request to start Yuva clinics or the adolescent clinics in the outpatients, at least the OPs, where not much of investment is required. And we had many meetings with the heads of the department of different medical colleges to motivate them to start this clinics. And in my own hospital, as Dr. Hari said, we do see up to 18. And I was also, contesting with my other pediatricians. There's no geo saying that 12 years. I tried to also see in all the antique, geos. So there was no geo. I don't know from where this 12 years has come. I keep, saying that UNICEF, all the departments or the global, the child definitions up to 18. So why are we stuck up with 12? So, but then at least outpatient we should start. There's a good positive feedback I got, sir, from Ms. Joya and from the Ministry of Adults and Health. So they are going to, we have put a letter from AHA and we are going to follow it up. And of course, like Dr. Hari said, a lot of the competencies are included as per NMC in the pediatric curriculum, both UG and PG. So there is a change, sir, but exposure, of course, is still not adequate for our postgraduates, and we have to all work towards it, sir. But it'll take time. We have started the advocacy strongly, sir. It was going on for many years. I think many people must have done it, but we are doing very strongly this year. It's 25 years, and we need to achieve this. And 18th of every month, celebrating Youth Wellness Day, and the declaration of 7 organizations committing to reach out to 1 million and one dedicated day in a month. This was also a landmark event, sir, this year. So the ministry and everybody is being involved in this endeavor. So just wanted to share this with you.
Madam, the 12-year probably didn't come by a executive order. It came because we only had half bed in the pediatric ward.
Small beds, yes, sir.
Small bed, half bed, we
Yeah,
call it.
yeah.
So you
So
can't
now, sir,
accommodate anybody. If it is
yeah,
13, he cannot
yeah,
be accommodated, she
yeah,
cannot be
sir.
accommodated.
So
That
now in the
probably that's
recent,
why the 12
in
came.
the recent NMC, this thing, sir. Now we are no more having small beds in all our hospitals. We are asking because the mother also has to sleep with the baby. We are saying bedding in. So we are want all big beds now. We are putting in the pediatric wards, or at least in the new hospitals, in the new
But the
medical
point
colleges.
is, the AHA also has to take effort to train pediatricians. I started the adolescent course with the Kerala University years ago. See, all
Yes,
the adolescent pediatricians, including you, are because
yes,
of
sir.
that one.
All we are all students, sir. Yes, sir.
No, I'm not saying taking credit for that, but I'm saying some concrete action has to be done. Just
Yes,
by
sir.
saying things won't happen. I got an opportunity to push with the University of Kerala. Now that is done. Almost 90% of the adolescent pediatrics are trained into Antrim. So like that, something we need to push.
Yes,
Action
sir.
has to be taken, madam. Then only we can make.
We'll do it, sir. We'll
Yeah.
do it. We are getting everybody together, and a huge advocacy, and Harish and all will take everybody's help, and we are started it, and we'll do it more aggressively.
And
That's
involve
my
Samir
commitment.
Galbhai, madam. Involve, he is the most vocal person I have seen.
Yes,
Involve
sir.
him in a
Yes, sir.
big
He's
way.
also working for with the ministry. Definitely, sir. I'll work with him.
Yeah.
Doctor,
And-
we are running out of time. Maybe if some other people want to pitch in.
yeah. We only have another, actually 10:30 over, but 5 more minutes.
5 minutes.
More minutes. Anybody in the audience want to say?
Samir Shah, you want to say something?
You already said.
Okay,
I already
Pembe,
said.
Jayant Bhai, Jayant Upadhyay.
Jayant Upadhyay, quickly, some small comment.
Good evening, everybody. It was a wonderful discussion listening to all the doyens. I am thrilled to be here. And one thing came to my mind that dealing with adolescents, hello,
Yeah, go ahead.
dealing with adolescent, the pediatrician should put themselves in the shoes of that adolescent. And they also should ask the parents to think what is going on in that small mind. Instead of or leave apart organic problems, but psychological and emotional issues can be dealt up when you try to imagine what must be going on in that head, and then only we can approach it. Very easy to classify the disorders and all these things, but exactly what is going on has to be ascertained. And
Fine.
that is what a pediatrician can do better than an adult physician, because that transition is not easy. He is not my doctor, that is what they say. Even I am practicing since last 33 years, and I have a patient who is 45, 48 years old. Now they have become father and they are on the verge of becoming grandfather. Many of you must have seen the grandchildren also. So they believe in you more compared to an adult physician. They are very reluctant to go to them. As already Dr. Nair sir has told that the super specialist can be involved.
No, so Jayant, we are not discussing the need. Everyone agrees. The question is how to do it at the level. That's the question.
So point well taken.
Sir,
You mean we should be empath? We should be empath.
Yes. In Maharashtra, many of the medical colleges are now doing that. Not 12 years. I think it is 15 years in many medical colleges.
Okay.
So I think for general pediatricians, I think for general
so that we can
general pediatricians, what is important is we had designed a card from 0 to 18 with a growth chart and all that. If you can have your private patients, ask them to come once a year. That's all. Not for every time. Even once a year before the birthday, you keep the tag of it. Your assistant can call them. Is your next birthday coming in next week? Congratulations. You have got an appointment? Please come. That may help, because even once a year contract will make sure. Because why I'm saying is, a lot of my patients who actually didn't come in between, now they come back and say that child had depression from the age of class 7 or 8. Then I feel bad. I missed them totally, because we didn't have a system of following up. General pediatricians can have a system. You have a card and you give them and ask them to come once a year only. And third thing is RKSK, Rashtriya Kishore Swasthya कार्यक्रम. You get involved, you get all the schools, ICDS completely under your head. You need not be treating the acute emergency all the time. That could be gone to the medical people, doesn't matter. But we will be the pediatrician doctor of the child. That's the point, adolescent.
Excellent. Yes.
I think Ramesh bhai, time to wrap
Yeah,
up.
yeah.
You can summarize the whole thing, and you can final word from you, Ramesh.
Nitin bhai.
No, you, Ramesh.
Yeah. Okay. Thank you so much, M.K. Nair, sir, because you are nowadays very rarely seen on platforms, and thank you so much for your time and consideration. And definitely, I'm very sure that our viewers, they enjoyed both the episodes. I am thankful to all three panelists, Dr. Harish Pemde sir, Dr. Geeta Patil ma'am, Dr. Samir Shah. Thank you so much, Dr. Samir Dalwai and Dr. Hima Bindu ma'am, for expert comments today. And I acknowledge the presence of our past VP, Dr. Jayant Upadhyay, and Dr. Shyam Sidhana, and so many other friends. So looking forward to next month, yet another topic will be chosen by Dr. Nitin Shah sir. And for the information of our viewers, that the recording link will be available from tomorrow only. So please, those who have missed part 1 and part 2 can sit at ease in the comfort of them home and can watch these two beautiful programs. Thank you so much, everyone. And last but not the least, Dr. Nitin Bhai, who always involves himself so much in each and every topic. So every month we come out with a very vibrant session, and I give full credit to Dr. Nitin Bhai, because sometimes he becomes rheumatologist, sometimes he becomes hematologist, sometimes endocrinologist. So my special thanks, Dr. Nitin Bhai. Thank you so much. And our
Nitin, have you become a grandfather?
No,
Not yet.
not yet.
Have you?
Not yet.
Yet. When you become grandfather, you get interest in everything.
And last but not least, Dr. Kunal Shah, our scientific coordinator, who is responsible for all the arrangement. Thank you so much, Kunal. Thank you, everyone. Good
My
night.
sincere thanks to
Good
the
night.
Gujarat Pediatrician Group. Thank you.
Thank you.
Thank you.
Thank you very much
Good
for the
night.
opportunity, sir.
Thank
I'm
you.
looking forward to future associations. Thank you so much.
Ramesh bhai, thank you.
you.
Bye.
Good
Bye.
night.
Bye.
Sir,
Good night.
Sir, thank you.
Namaskar. Himaji. Nice.
Thank you. Thank you, Samir ji. Thank you, everybody. Thank you, sir. MKC Nair, sir.
Thank you.
Nitin
Thank you.
sir.
Thank you.
Thank you.